target just your bronchioles, and you wouldn't have a problem with side effect, heartbeat faster anymore. So that is the answer for number 9. Number 10, an anticholinergic agent was also suggested as a possible nebulizer agent. How might this help the breathing problem? Remember, anticholinergic means acetylcholine, blocking that. Now, your sympathetic division is using your adrenergic, your norepinephrine, right, as well as some acetylcholine. But your parasympathetic is actually using all of the neurotransmitters there are your acetylcholine. So when you are blocking the acetylcholine, you're blocking the parasympathetic division, and that is what we want. Remember, parasympathetic is causing the bronchoconstriction. So when you're blocking that, if you're not constricting it, you're dilating it. So that is why anticholinergic agent in her case would work out. So that was the end of case study 1, and I know that took a while. It's a long case. The case study 2 has a lot more calculations in here. This is about a 150 pounds, 62-year-old man who had a chronic productive cough, exertional dyspnea, mild cyanosis, and marked showing of forced expiration. His pulmonary function and lab tests showed the following results. For frequency, 16 breaths per minute, which is high. Alveolar ventilation was 4.2 liters per minute, which is kind of low. Normal is 5.0. Vital capacity was 2.2 liters, which is again low. Functional residual capacity 4.0 liters, that is high. Total lung capacity 5.2 liters, that's low. Maximum inspiratory flow rate is okay. Maximum expiratory flow rate is 20 liters per minute, which is not normal. Partial pressure of oxygen is 62, which is very low. Remember, normal is at least 70 something and higher. Partial pressure for carbon dioxide is 39, which is okay. So that was the lab results. And knowing that, so you know so far that he has, the symptoms are his cough, which is chronic and productive, which means there's sputum in there. It's not the dry cough. Another symptom was exertional dyspnea, which means that whenever he's trying to do some kind of work like exercise, he has difficulty in breathing. Another problem was mild cyanosis. Remember the skin turning blue? That happens when your oxygens are not carried in hemoglobin or oxygenated blood. You have more deoxygenated blood around your skin, so you have cyanosis. And the last one says marked slowing of forced expirations. So when that happens, what happens is usually a wheezing sound that you get in before your expiration. So that wheezing sound causes a slowdown of expiration. Now this does not happen with asthma. Asthma does not have a marked slowing of forced respiration. But asthma and the disease we're talking in this case is actually very similar. This is emphysema and asthma. Both of them has almost similar kind of symptoms. But you see, another thing you see in this case is when you have a pulmonary function test given after the bronchodilator therapy, you see most of these values changed a little bit, but they are not close to normal. Asthma results, as soon as you gave the bronchodilator, you saw that the patient had all the results close to normal. This case did not work out, and that is because the problem in his case, this 62-year-old man, his problem was not in the bronchus, it was in the alveoli, which is why dilating the bronchus did little to nothing in his case. And emphysema is that problem. This is a disease where the problem is directly into your alveoli, into the acinus cells there. That's the site where the tissue damage happens. The problem is smoking. Most of the time, most emphysema is caused by smoking. Asthma, on the other hand, does not have to be smoking. It could be any kind of allergies, any kind of immunological disorders can cause asthma, genetic. So emphysema, another problem of this is that whenever you have the tissues, lung tissues being damaged into your alveoli, the airspace there can enlarge, and that can cause problems when you're trying to, expiration can cause a problem when you have an enlargement of that space in there. It works the same way as an obstructive disorder, actually. So, looking at the rest of the values here, after the treatment, you can see all of the values has changed a little bit, and it's not even close to normal. Okay, the first question here is, what is the disorder of this 62-year-old man? Like I said, emphysema, shortness of breath, cyanosis, cough, all of this with the sputum, all of this indicate that he has emphysema, and the fact that the treatment did not work on him, again, emphysema. Number 2, is this primarily a restrictive or an obstructive disorder, and why? Again, this is an obstructive disorder because look at the values for your FRC here, and you can see that that value has not changed even after the treatment. It's still close to 4.0 liters, so that is still high, and your total lung capacity is low. All of that says that there is an obstructive, there's an obstruction somewhere. So we conclude that it's obstructive primarily, but it can also have some restrictive sides to it, but we will ignore that for this question. Number 3, why is the bronchodilator therapy ineffective in this man? Well, the problem is in the alveolus and not the bronchus. So dilating the bronchus will not do much. Number 4 says, what causes the hypoxemia? Again, your functional residual capacity here is very high, which tells you that there's a lot of residual remainder in there, so which means that the surface area in your alveolus, remember where gas exchange is happening, we said that the lung tissue is destroyed in emphysema, so when that happens, the surface area there is more, it increases, and also because the alveoli does not have the ability to recoil between breathing, so that increase will cause the man to have problems with oxygen exchange, so she won't have enough oxygen exchange between alveoli and blood due to that lung tissue damage in your alveoli. So that was number 4. Number 5 says, calculate the residual volume for this person before and after the bronchodilator therapy was used. So again, you just take the values straight from before and after. When you know that your RV or your residual volume equals total lung capacity minus vital capacity, all you do is get your total lung capacity, 5.2 in this case, minus your lung capacity, vital capacity, which is 2.2 in this case, and deduct that from there, and you get 3.0 liters in here. So that is before the treatment. After the treatment, again, it changed a little bit. So 5.2 minus 2.4 equals 2.8 liters. So from 3.0, it became 2.0. Remember, normal RV is 1.2 liters, so it's not even close to normal. So that was number 5. Number 6, what is the cause of this altered RV? Your alveoli has lost your elastic ability to recoil back because of the tissue damage in there. So whenever whenever you have to expire or get this air out from your alveoli to a bronchus and out, You can't do that when you don't have that pressure to close back, recoil. So what happens is